Hello, Anand. Good evening.
Good evening, sir.
So, can you request Dr. Tiwari to be there for 1 or 2 minutes?
Okay, sir.
Yes, just request him for, when Aditya is here, so he can, be there for 2 minutes. Dr. Aditya, are you there? Hello?
बहुत सर अभी ज्वाइन नहीं किया है.
ये नहीं है अभी join. मैं एक बार कॉल करूं उनको. Sir, we are waiting for you. Hello? Hi. अनंत,
जी सर।
क्या रिस्पॉन्स था? सर आ रहे हैं?
सर अभी वो मुंबई में लैंड किए हैं।
अच्छा अच्छा, लैंड किए हैं।
हाँ हाँ, ट्रैवलिंग कर रहे हैं, बोले ठीक है हम देख लेते हैं।
हाँ, आइए सर, गुड इवनिंग। राइट राइट राइट, थैंक यू, नो प्रॉब्लम, एब्सोल्युटली एब्सोल्युटली।
सर गुड इवनिंग।
हाय, गुड इवनिंग।
वो सॉरी सॉरी,
नो प्रॉब्लम्स, नो प्रॉब्लम्स।
2 मिनट दीजिए सर।
हाँ हाँ, यू कैन टेक एनी नंबर ऑफ मिनट्स।
सर सॉरी सॉरी।
हाँ,
हाँ, यस सर, आई एम रेडी।
so we welcome you on behalf of API Dean's office, and on behalf of Dr. Tiwari and all the stalwarts of API, and we are finally able to catch you.
अरे सर
this very special occasion. Uh, and I know that you are masterpiece of everything, especially the electrophysiology in cardiology. You have really given us a lot of sessions in Patna, and you have taught us a lot of arrhythmia and EP like thing. So, uh, on behalf of API and the dean's uh, short course in cardiology, I'm inviting you on this special day. Uh, uh, please go ahead with your talk. Dr. Aditya Kapoor doesn't need any introduction. He is HOD and director of cardiology department at SGPGI Lucknow. He has many accolades in his uh, uh, kitty. I would say that he has been a masterpiece teacher. He has blessed many occasions at Patna. So over to you, Dr. Aditya.
Thank you, sir. Thank you so much. Am I audible, sir?
Yes, yes, yes.
So I think at the outset, सर का तो मुझे थैंक्स करना ही है. We have had many sessions together, और सर का enthusiasm not only as a teacher but to keep on learning things is unmatched. हम लोगों ने कितने एयरपोर्ट्स पे ECG डिस्कस किए हैं और कुछ कुछ अरिथमिया की ट्रेसिंग डिस्कस करी है. सॉरी मैं कुछ मिनट लेट हो गया, तो आई जस्ट शेयर माय स्क्रीन. ये आ गया स्क्रीन पे. ECG पे आ गया सर, स्क्रीन पे आ गया, स्क्रीन पे आ गया सर. सर आप म्यूट पे हैं.
Yeah, नहीं, you are audible and it is visible very
इट
well.
इज विजिबल. मैं चलता हूँ सर फिर आगे. तो many थैंक्स सर को. और सर ने मुझे बोला था कुछ ECGs इंटरेस्टिंग जो फिजिशियंस के पॉइंट ऑफ व्यू से हो, तो वी जस्ट हैव सम ECGs हेयर. तो फॉर इंस्टेंस ये पहला ECG है. एक मिनट, आई जस्ट मूव दिस आउट. एक मिनट सर. हाँ, ये इसको मैं नीचे ले जाता हूँ कहीं. So this is a 62-year-old male hypertensive diabetic for 5 years having a left arm discomfort for 4 hours. So ECG अगर हम देखेंगे तो this shows a, सर ECG आ रहा है ना स्क्रीन पे?
बिल्कुल आ रहा है, बिल्कुल आ रहा है.
वो shows a isoelectric lead 1, or there is inversions in 2-3 AVF over here. So it was referred as a evolving acute coronary syndrome for activation of the lab. तो पॉइंट यही था दिखाने का इस ECG को कि देर इज आइसोइलेक्ट्रिक लीड 1 इज देयर आर सम टी वेव इन्वर्जन्स. तो फिर हम लोगों ने इसको जब और एनालाइज किया, अगर आप देखें तो कंप्लीटली नेगेटिव लीड्स हैं इन 2-3 AVF. द एंटायर PQRS, इवन द टी वेव इज इन्वर्टेड, द QRS इज इन्वर्टेड, द T इज ऑल्सो इन्वर्टेड. तो अगर इंफीरियर वॉल इस्कीमिया होगा तो व्हाई शुड द P wave get inverted, although it can happen in a low atrial rhythm, but this should set some thought process going कि what we are dealing with. तो आइसोइलेक्ट्रिक लीड है, कंप्लीटली नेगेटिव है, एंड लीड AVR इज कंप्लीटली अपराइट. AVL तो खैर अपराइट है ही, बट AVR इज ऑल्सो कंप्लीटली अपराइट. सो वन शुड वंडर कि कोई लीड मैल पोजिशन तो नहीं है बिफोर यू सॉर्ट ऑफ रश द पेशेंट टू कैथ लैब और यू थिंक ऑफ थ्रोम्बोलाइजिंग ऑल्सो. तो अभी मैं आपको एनालिसिस आगे बताऊंगा. वी सस्पेक्टेड इट्स अ बायलैटरल अपर लिम्ब लोअर लिम्ब रिवर्सल. तो इट्स अपर लिम्ब भी रिवर्स्ड है, लोअर लिम्ब भी रिवर्स्ड है. सो रिपीट ECG किया फिर विद करेक्ट लीड प्लेसमेंट, एंड इट इज कंप्लीटली नॉर्मल. तो अब इसका मैं एनालिसिस बस क्विकली बताता हूँ. तो ये हम लोगों ने इधर वो अपना वी हैव दिस फिगर्स ओवर हेयर जो नॉर्मली रहती हैं हमारी. सो अगर आप देखिए तो दिस इज लेफ्ट लेग. इसको उल्टा कर दिया किसी ने, आर्म्स नीचे ले आए हैं हम. लेफ्ट आर्म राइट आर्म और सर नीचे हैं, लेफ्ट लेग राइट लेग ऊपर है. सो इट इज कंप्लीटली लाइक अ टॉपसी टर्वी ECG. तो लीड 1 विल रिकॉर्ड अ जीरो पोटेंशियल, बिकॉज लीड 1 जो है वो जीरो पोटेंशियल अब हो गई, नीचे आ गई. लीड 1 आइसोइलेक्ट्रिक बन जाएगी। लीड 3 इज टोटली इन्वर्टेड। तो लीड 3 अगर हम देखें, लीड 3 इधर आ गई, लेफ्ट आर्म लेफ्ट लेग इधर आ गए, तो लीड 3 बिकम्स टोटली इन्वर्टेड। Now leads 2 and AVF, they will appear identical and similar to the inverted lead 3 because they are measuring the potential difference across left arm and left leg. So lead 2 and AVF will become similar to lead 3. और जो न्यूट्रल इलेक्ट्रोड है राइट लेग न्यूट्रल इलेक्ट्रोड रहता है, is now displaced. So this makes AVL and AVR mathematically identical. So they will appear similar. So the point is recognize अगर कोई भी लीड आइसोइलेक्ट्रिक है, अगर लीड 2 3 AVF टोटली इन्वर्टेड है, PQRST पूरा ही इन्वर्टेड है, so there is something amiss. So we published this, sir, actually unusual case of a topsy-turvy ECG with a pseudo infarct pattern. So the point is a quick and easy way to suspect such a bilateral, क्योंकि complicated लगता है सुनने में, बाइलैटरल आर्म लेग, हम लोग लेफ्ट आर्म लेफ्ट लेग रिवर्सल तो बड़ा कॉमनली देखते हैं। इसको सस्पेक्ट करने के लिए अगर लीड 1 आइसो इलेक्ट्रिक है और लीड 3 इज कंप्लीटली इन्वर्टेड and it is looking similar to lead 2 and AVF, so this is the way you can suspect. In fact, हम लोग अपने रेजिडेंट्स को कई बार encourage करते हैं when we are free in the cath lab, so play around with the ECG malpositions, so you know you will be able to sort of figure out कि कैसे क्या है. So do not ignore, first message for today is do not ignore isoelectric leads and pay attention to leads with inverted PQRST. सर मेरा टाइम कितना है? 20 मिनट 30 मिनट्स है कितना है?
नहीं, 1 hour है।
1 hour, अच्छा अच्छा ठीक है फिर तो सेकंड पेशेंट सर है 40-year-old hypertensive recurrent syncope. So this patient was again referred for an intracardiac defibrillator, and अगर ECG हम देखें तो obvious there is a polymorphic VT torsades going on नीचे rhythm strip पे, so she was referred for an ICD. तो we shocked her and obviously अब एक instinct होती है कि the patient has having recurrent syncope, polymorphic VT torsades हो रहा है तो उसको ICD की जरूरत लगता है कि हो, बट जैसा कि we have learned in so many ECG workshops with Dr. Ajay also, हम लोगों ने किया है, डॉक्टर यश के साथ किया है, डॉक्टर अमित के साथ किया है, every patient should be managed in a very systematic way, so we should not jump to conclusions. तो इस पेशेंट को हम लोगों ने शॉक किया, and after the shock this was the ECG which shows some relative sinus bradycardia. But the most striking thing, sir, is the prominent deflection seen in the precordial lead, which is the obvious U wave. So इस पेशेंट को न केवल साइनस ब्रैडिकार्डिया था, वेरी वेरी प्रोमिनेंट यू वेव, और QT भी थोड़ा prolonged है because if you include the U wave, so there's an obvious prolongation of the QT. If we bisect the RR interval into two, T wave is following on the right side of the line. So खैर इसका potassium was also 2.7 and she is a hypertensive. So 40-year-old lady, hypertensive, recurrent syncope, prominent U waves in the ECG. In fact, because hypokalemia था तो we got her investigated further. उससे पहले उसको कोई history नहीं थी. And if you see the CT, it showed a big adenoma. So it showed a big adenoma, and she was actually operated and of course did not require an ICD. So this is the gratifying part कि ancillary workup की भी जरूरत पड़ती है कभी कभी. One should not jump to conclusions because यदि इसका cause ना pick up होता, and simple things like which we have been taught in general medicine कि pay attention to the ECG, always do a electrolyte workup, सिंपल एक्सरे भी होना जरूरी है, पेशेंट को स्टेथोस्कोप भी लगा के देखना जरूरी है. सो इनफैक्ट शी हैड एन एडेनल शी हैड एन एडिनोमा, शी गॉट ऑपरेटेड, एंड दिस द फर्स्ट केस शोड कि भाई आइसोइलेक्ट्रिक अगर लाइन भी आ रही है ECG में उसको इग्नोर नहीं करने का. एंड द सेकंड ECG टीचेस अस द यूटिलिटी ऑफ एन एंसिलरी वर्कअप. So third case मैं थोड़ा सा gear switch करूंगा for a respiratory. I mean there's a lot of I think ED physicians होंगे emergency के. So this patient was in the emergency और जैसे कार्डियोलॉजी में कॉल आ जाती है so they sent ECG on the WhatsApp या ECG कई बार अटेंडेंट्स भी सर बिजी इमरजेंसी में जैसे मेडिसिन में वो भेज देते हैं कि ECG पढ़ लीजिए. तो हम लोग भी रेजिडेंट्स को कहते हैं कि आप ECG तो देख लो बट इट इज ऑलवेज बेटर टू गो एंड एग्जामिन द पेशेंट फर्स्ट इफ इट इज पॉसिबल, बिकॉज ये ऑब्वियस If the ECG shows it looks like a acute evolving inferior wall MI, lead 2-3 AVF में obvious ST elevation है. But again है ST elevation, हमेशा पेशेंट का हिस्ट्री एक बार जान ले और पेशेंट को एक बार देख लेना बहुत जरूरी है. So when the history was taken, it showed a, सॉरी सर चाय पी रहा हूँ साथ साथ तो आपकी इजाजत चाहूंगा. So 47-year-old female who was admitted to the emergency department with 6-hour history of dyspnea, cough and wheezing. तो इसको respiratory symptoms भी थे, which again can be there in a cardiology patient also. So अब instinct क्या रहती है कि इसको थ्रोम्बोलाइज कर दें या प्राइमरी पीसीआई के लिए ले लें, which is probably not a wrong decision, but since history ऐसी थी, so now the decision is rush to the cath lab अगर आपके पास प्राइमरी पीसीआई है, या थ्रोम्बोलाइज कर दें. ट्रोपोनिन अब इसका हुआ जो इमरजेंसी में रूटीन प्रोटोकॉल था, तो ट्रोपोनिन वाज 0.08 अगेन विच इज अ बिट सरप्राइजिंग, क्योंकि 6 घंटे की हिस्ट्री है. शी इज ऑलरेडी इन द ड्रॉप विंडो विद सच ईसीजी राइज इन द एसटीज. ट्रोपोनिन उतना कमेंसुरेट नहीं है, सो ट्रोपोनिन शुड कुड हैव बीन हायर. The other thing was echo was also normal. So ED physician had the good sense to do an X-ray. X-ray shows a right tension pneumothorax. अब इसकी हिस्ट्री भी थी डिस्निया की, कफ की, वीजिंग की. सो अगेन द प्राइम रूल इज इफ यू हैव टाइम यू शुड एग्जामिन द पेशेंट. एग्जामिन पेशेंट को जब किया गया ऑब्वियसली तो पेशेंट हैड डिमिनिशन ऑफ ब्रेथ साउंड्स ऑन द राइट साइड. So the point is that sometimes pneumothorax can lead to such dramatic ECGs, and if we अगर हम इसको मिस कर दें और पेशेंट को लैब ले जाएं तो it will be a disaster. Not only will the coronaries perhaps be normal, but we'll be missing the diagnosis completely. इसको ट्यूब डाला गया and some time after the tube look at the ECG. It is absolutely, this was a really stunning case कि sometimes pneumothorax respiratory problems can lead to such dramatic ECGs. थोड़े बहुत ST shifts तो हम देखते हैं, पर इतना remarkable shift is quite unusual. So the patient actually had serial biomarkers also done. Echo, as I said, repeated echoes showed no regional wall motion abnormalities. And just to be sure, इसका एक CT coronary भी करा लिया गया, just to be sure. So CT coronary was also normal. So again, the point is that such dramatic ECGs can occur. Again, I'll be on the respiratory side only. Another call from the emergency, if the ECG, if you see over here now, ये lead 1 है, lead 2, मेरा pointer शायद visible होगा, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So the ECG again shows some ST elevation in the anterior precordial leads. Again, one cannot be faulted for making a diagnosis of evolving acute interval MI. वो जैसा मैं रिटरेट कर रहा हूँ, आई एम श्योर सर भी अपने स्टूडेंट्स को बताते होंगे कि एक बार पेशेंट की हिस्ट्री लेना बहुत जरूरी है, रादर देन ब्लाइंडली सी द ईसीजी एंड डिसाइड रिमोटली कि क्या करना है. सो द पेशेंट हैड सीवियर सीओपीडी. he had known coronary artery disease, he was hypertensive, he was diabetic, so background coronary artery disease का जरूर है इसको. He was admitted in the emergency for shortness of breath. Now, shortness of breath is a very non-specific symptom. It can be respiratory also, it can be cardiac also. कुछ भी हो सकता है. But another history was कि उसको ED physicians या anesthetists जो भी था emergency में, they were trying to put a right IJV line, central line डालने की कोशिश कर रहे थे. When the patient suddenly became hypoxemic, developed respiratory failure and needed to be intubated. और ये ECG उसके बाद का है. So patient को right IJV line डालते डालते became hypoxemic. So now obviously अगर right IJV line डाल रहे हैं, patient has become hypoxemic, needed intubation, you will obviously think again of some respiratory problem, and this ECG was done concomitantly at that time because patient became hypoxic, hypotensive हो गया. So people thought कि कोई coronary event ना हो गया हो. And again the X-ray जैसे पिछले केस का था. So this case was obviously more illustrative. It was more in the face like कि भाई इसकी तो history वैसी थी, right IJV line डालते डालते होता, but the right pneumothorax is completely apparent. Again the tube was put और ये देखिए ECG after about 3-4 hours it is completely settled. So the idea of showing two cases is कि कई बार in a pneumothorax what happens is that the pressure on the heart and coronary vessel can precipitate ischemia. Sudden onset hemodynamic changes, there is hypotension, there is hypoxemia. Pneumothorax की वजह से there is a elevated myocardial oxygen demand, there is tachycardia, and increased intrapleural pressures will further decrease the cardiac venous return. Cardiac preload or compromise होगा. There is cardiac rotation. There could be a rise, acute rise in the pulmonary vascular resistance. So again, these funny looking ECGs can happen. The point is, जैसा पहले केस में था, नेवर अंडर एस्टिमेट एन आइसोइलेक्ट्रिक लाइन. सेकेंड केस में था, नेवर अंडर एस्टिमेट एंसिलरी वर्कअप. इस केस का हाईलाइट या मैसेज इज नेवर अंडर एस्टिमेट अ चेस्ट एक्सरे ऑल्सो, बिकॉज ऑफन आई एम श्योर सर तो पीजीआई से ट्रेंड है, चंडीगढ़ से. पहले हम लोगों को भी सिखाया जाता था ऑस्कल्टेशन, चेस्ट एक्सरे. दीज आर दी prime things which are helping us evaluate a patient. So lack of time is not the issue. The point is one should make a effort to take a proper history, take a proper 12 lead ECG, and at least if it is possible, X-ray भी देख लेना चाहिए. So जैसे मैंने 12 lead ECG बोला, so कई बार आजकल ट्रेंड है कि मॉनिटर स्ट्रिप पे देख के भी कई बार डायग्नोसिस बनाया जाता है. So this is another case of a 21-year-old guy who had some एक मिनट सर, sorry. So 24-year-old guy who had shortness of breath and dizziness. His blood pressure was 90/60. एक systolic murmur भी सुनाई दे रहा था clinically. Now this was the ECG which was on the monitor. So now what should we assume? Supraventricular tachycardia, ventricular tachycardia, can't say. I think most of us, including me, if we are shown this ECG या सर को भी दिखाएं तो हम लोग हो सकता है सेफर साइड के लिए VT ही बनाएंगे, because broad QRS tachycardia लग रहा है. Now the issue is VT in a 21-year-old guy can occur. The blood pressure is borderline. Systolic murmur क्यों है इस patient को? So again, that is a point worth thinking about, and the ECG shows a broad complex rhythm. So now the point of again showing this is कि monitored strip पे arrhythmia का diagnosis बना सकते हैं, but final definitive diagnosis avoid करना चाहिए. Always try to take a 12 lead ECG. So this was पुराने ECG में ये V1 strip थी. So I'll again put V2, V3 also now. तो अगर मैं V2, V3 ले आऊं इधर, तो अगर आप देखो, नोट द QRS. ये QRS है V3 में. दिस इज अ डेफिनेट QRS. V2 का QRS ये है, तो ऑब्वियसली V1 का QRS ये है. तो नाउ इफ यू सी, मेरा पॉइंटर सर दिख रहा है? इस बार पॉइंटर विजिबल सर? आप म्यूट पे हैं सर?
It is very much visible, sir.
ओके सर, सॉरी. सो QRS ये है. सो ऑब्वियसली दीज आर द P waves. So I'll mark out this is a QRS. So these are the P waves V2 V3 में. तो अगर ये V2 V3 की P waves हैं, V1 की P waves ये हैं, because they are simultaneous leads. तो अगेन समटाइम्स V1 के अंदर इस पेशेंट में, अब मैं 12 लीड ECG ले आया इस पेशेंट का. आप देखो V1 ये थी. Now you see the other leads. So it's obviously a atrial flutter which is going on with variable AV conduction. So अगर मैं केवल V1 देखूंगा, I'll be fooled into making a diagnosis of VT. Same patients, if you see V2, V3, more apparent in the limb leads, he had a atrial flutter which is ongoing. तो अब इसका एक्सरे ये था. So again, now we put everything together. 21-year-old guy, systolic murmur, massive cardiomegaly. So he had Epstein's anomaly. So Epstein's anomaly with atrial flutter. तो अगर हम single lead देखते तो we will make a diagnosis of VT. But if we see the multiple leads, we would obviously make a diagnosis of atrial flutter with variable AV conduction. So the point is, fourth message for today is, always, if you have the time and if you have the opportunity, use multiple leads for making a complete diagnosis of an arrhythmia. By and large, avoid making a diagnosis of VT or SVT based on a single lead if it is possible. Fifth case for today. अगर ये देखिए फिर again, this is one of our own cases which was very, very interesting. So this was a 61-year-old female who had no diabetes, no hypertension. She was a non-smoker. She underwent a transbronchial lymph node biopsy in the pulmonary ICU. और उसके biopsy के कुछ ही मिनट के बाद she developed restlessness, diaphoresis, hypotension, and the ECG which was sent to us again shows massive ST elevation in multiple precordial leads, 2, 3, AVF, V1, V2, V3, V4, V5, V6. So since I have shown you those examples, one always thinks कि और कोई alternative diagnosis तो नहीं है. But इस case में obviously it was an emergency. She was hypotensive, restless. ECG में इतना gross ST elevation था. Obviously, since they were doing a transbronchial lymph node biopsy, they did an X-ray, and X-ray was normal. So there was no pneumothorax. Echo भी कर लिया bedside intensivist ने, but showed a severe global hypokinesia. Ejection fraction was only 30%. And prior to that, she had no cardiac history. So we had no echo report documented, but the relative said कि कभी एक बार कुछ echo हुआ था, शायद normal ही था. But obviously, given the context of this, we said, okay, transfer the patient to the medical ICU, and we will probably consider doing an angiogram, because we need to understand LV function भी drop हो गया है, there is massive ST elevation. Now, while the patient was being transferred to the MICU, अगर आप यहाँ इस ECG को और ECG को compare करोगे, there seemed to be some reduction in the precordial leads elevation, especially if you see, I'll again bring the inferior leads. ये inferior में यहाँ पे अगर देखें 2 में, 3 में और lateral leads में, so there is about 5 to 6 millimeter ST elevation. While she was 15 मिनट के बाद जब वो आ रही थी, there seems to be some drop in the ST elevation. So we had the cath lab ready. Troponin भी करा लिया. Troponin was also very, very high. So we were also quite convinced that she had some cardiac event. LV भी खराब था and the ST was there. But since the ST was settling, we thought, okay, while the lab is being readied, let us do two more serial ECGs while the patient is being transferred to the cath lab. So she had a brief run of rapid VT, which settled. She did not require any cardioversion. So since the ECG was settling, we waited about 20-30 minutes more. And the ECG completely normalized, to our surprise. And we put her on some inotropes. And 2 days later, we didn't do the angiogram the same day. We thought we'll wait because the patient's condition had improved and the ECG settled by evening. So we thought we'll hang on and wait because the coronaries were done the next day, completely normal. The LV function recovered. So this was like a Takotsubo cardiomyopathy precipitated by whatever pulmonary cause, transbronchial lymph node biopsy, malignant vasospasm. So we never ever seen that. So we again published this unusual complication during bronchoscopy, because the reason for publishing such cases is to share with other physicians that these things can happen and they are rare causes. So this case again highlights the importance of serial ECGs. Again, if you have the time, obviously if the patient is deteriorating, you might want to take her to the cath lab, do a quick angiogram, and then see what happens. But we were fortunate that we had time, and again, serial ECGs over 10-15 minutes showed rapid resolution. So again, the context of the patient is very, very important. So I'll move on to the sixth case. I think we still have time. This was a 49-year-old diabetic male who was in the emergency. He was feeling a bit lightheaded. Pulse rate was 50. The blood pressure was borderline 100/60. Slightly tachypnic, and SpO2 was 97. Now, this was the ECG. So diabetic male hai, feeling lightheaded, bradycardic slightly. ECG shows some junctional rhythm. Occasional P waves are there. Some ventricular ectopics. So there is a junctional rhythm, definitely. There is a ventricular ectopic, and there is a hint of a prolonged QT. So we measured the QT. It was around 600. So one is alert that the patient could have a impending tachycardia also. तो ये patient की शक्ल ऐसी थी. You see this reddish tinge all over the body, and his urine was also a bit funny colored, not hematuria. So we were actually confused कि इसको हो क्या रहा है. Immediately following admission, he had sudden monomorphic VT with hemodynamic compromise. and again cardioverted. कार्डियोवर्जन के बाद ही रिकवर्ड, इन द सेंस द रिदम रिकवर्ड। फिर जब इससे हिस्ट्री ली गई तो ही सेड दैट ही हैड इंजेस्टेड आल्टा, वो जो पैरों में लगाने वाला होता है ना सर, रेड डाई, वो जो लेडीज लगाती हैं बंगाल वगैरह में, इंडियन सब कॉन्टिनेंट में, 20 से 25 ग्राम खा लिया था उसने एक दिन पहले। सो of skin and urine, we have actually never seen this, and the reason for this discoloration. So slowly, I mean, she did not require any dialysis or anything. The ECG settled over a few days, and this was the color a few days later. So dramatic resolution. In fact, we tried to publish this also. A Liliac man with tachycardia alta karke, and we got his urine tested for the positive for azo dyes and paraphenyl dialamine, which is ये hair dyes में भी होता है, but it was found in alta as well, and it is a known arrhythmogenic, and it's a very common cause for suicidal cases being reported when people ingest they ingest hair dyes, etc., which have these PPDs and azo dyes which produce prolonged QT. So we found a bit fragment of azo dyes, but we couldn't find any mercury or any other solvent in the urine. But again, to show that sometimes in unexplained arrhythmias, I think Yash bhi bade example dikhate hain of importance of Ayurvedic and herbal medications which can produce digoxin-like arrhythmia. So this case was Alta, which we had never seen before, leading to prolonged QT. So this is again from the interventional point of view of people who are attending. So this is aortic trace from a cath lab monitor, and ये ECG है coming intermittently. Patient is not on any temporary pacemaker. The patient does not have a pacemaker in place. So we often show this to DM students as a quiz in exams, but interventionalists also need to be aware of it. कि आजकल सर को पता होगा कि जैसे ये पेसिंग स्पाइक की तरह आ रहा है, बट मैं जैसा बोल रहा हूँ, देयर इज नो टेम्पररी पेसमेकर in place in this patient. So now this is the procedure being done. Right coronary artery, this is the guiding. ये calcium दिख रहा है. IVL which is going on, intravascular lithotripsy, which is a calcium debulking technique. So इसको जब भी हम IVL करते हैं, so this is actually a in vitro video of the IVL. This is how it pulverizes or vaporizes the plaque. तो जब ये प्लाक को वेपराइज करता है, जो भी IVL जब हम करते हैं, वी गिव पल्सेस, द बलून इज earmarked to give pulses, so we press button और वो pulses to cut the calcium. So
Your voice is
they're called
cracking.
shock talks,
Aditya, your
and
voice
very
is
very rare. अच्छा, वॉइस इज
cracking, yeah.
अभी बेटर हुई सर कुछ?
हाँ, better.
अभी बेटर है सर?
Better है,
So
better.
whenever we do IVLs or stuff like, pulverize the calcium using IVL, we get these shock topics. The only significance is that rarely these pulsing spikes can fall on the T wave, lead to R on T. And these are rare case reports. But again, the physicians who are doing this procedure should be aware कि ऐसा हो सकता है. We have never encountered it in our lab till now, but I'm sure one has to keep an eye out for it. So these are examples of funny looking ECGs in the cath lab. Incidence is very, very less. So I'll again move to non-interventionalist thing. A 45-year-old male who underwent a treadmill test, and this is the ECG. The first glance by it looks as if the patient has got a very rapid tachycardia ongoing on the treadmill. So whether it's AVNRT, it's a pathway, atrial tachycardia, we are not sure. तो अगर ये यहाँ पे हम देखें सर, तो रैपिड एक टैकिकार्डिया लग रहा है, बट द क्लू इज, अगर नीचे की हम रिदम स्ट्रिप देखें, रिदम स्ट्रिप इट इज नॉट नॉर्मल. सो दिस इज अगेन अ कंप्यूटर जनरेटेड आर्टिफैक्ट. which is often seen in treadmills, machines. So you have to analyze the bottom strip. Mark out on this. If you see my pointer here, this is the normal QRS1. This is the normal QRS2. This is the normal QRS3. Beach mein it is picking up some artifact. So this is the artifact, and the star is the normal QRS. So this was not actually a tachycardia. Sometimes the machine will pick up or not the patient, which is not required. So these sort of funny looking ECGs, the only way you can make it out is if you see the bottom rhythm strip showing a normal rhythm. एक और केस मैं दिखाता हूँ. This was again we got a call from the anesthetist in the cardiac in the urology OT. They were doing some surgery on a 20-year-old male for a epispadias. Epidural procedure था under fentanyl, midazolam and propofol. So this was the picture they sent on WhatsApp. The patient is having some funny looking arrhythmia and they wanted to start amiodarone. तो ये येलो से मार्क करके उन्होंने भेजा था. So they thought it's a non-sustained ventricular tachycardia. The blood pressure was borderline 98/54. Saturations यहाँ पे दिख रहे हैं 94. It was normal. So now we told them that okay, proper cleaning के साथ they had done they had put in new electrode, they had taken a new monitor. वो कुछ नहीं हुआ तो they sent the ECG to the cardiology people. So we got this ECG. अगर आप देखें तो यहाँ पे नॉर्मल QRS ये रेड से मार्क किया हुआ है मैंने. Now if you see this, there is some bizarre looking yellow sync से QRS जो आ रहा है. Now since it is following so closely to the normal QRS, this cannot be a physiological contraction because previous QRS से already वो depolarize होके refractory चल रहा है ventricle. So we conjectured that this is obvious artifact. And अगर मैं फिर से repeat करता हूँ, this is a normal ECG, this red is a normal ECG, red is a normal ECG. So any other QRS cannot follow a normal depolarization so quickly. The ventricle is already refractory due to the previous QRS. So we hypothesized that this is a artifact, and we told them to okay check all the connections. तो वहां पे उन्होंने एक बॉडी वार्मर लगाया हुआ था पेशेंट का. तो बॉडी वार्मर से आर्टिफैक्ट से ये वाला वो फेंक रहा था. तो व्हेन दे डिस्कनेक्टेड द बॉडी वार्मर everything went away and we got a normal recording. So importance of artifacts also needs to be realized. We should not treat artifacts. लास्ट केस है. एक दो और केस का टाइम है ना सर अभी?
हाँ बहुत है. Please go ahead.
हाँ जी सर.
You have enough time.
सर. So again this is a very interesting ECG. Patient was in the emergency. Obvious acute inferior wall MI lead 3 is more than 2 and ST depression in lead 1. So obviously shows a RCA involvement. Now 2 hours later, patient was actually meant to be taken up to the cath lab. There was some delay or whatever was there. So 2 घंटे के बाद ये ECG भेजा गया. तो अब इस ECG को अगर आप देखें, so now the ECG shows ST elevation in the lateral leads. और inferior leads में T-wave inversion आ रही है. So what has happened? Has the inferior become lateral or has lateral infralateral extension होती तो 2-3 AVF में ST elevation गायब नहीं हो जाता. So again this is obviously again very common cause. जो पहला वाला मैंने topsy turvy दिखाया था वो थोड़ा सा complicated था. This is another common cause. Left arm left leg reversal के अलावा this is a very common thing which happens. Left arm left leg reversal. So this is easier to understand. मैं यही वाला लाता हूँ. This is the normal lead placement. तो ये लेफ्ट आर्म नीचे ले आए मैम, लेफ्ट लेग ऊपर ले आए. तो पहली चीज क्या हो जाएगी? लीड 3 इन्वर्ट हो जाएगी बिकॉज लेफ्ट आर्म लेफ्ट लेग ऊपर नीचे हो गए तो लेफ्ट लीड 3 विल गेट इन्वर्टेड. राइट आर्म अपनी जगह है. सो अब क्योंकि राइट आर्म अपनी जगह है तो देखा एक क्लास में हूं मैं, अभी कॉल करता हूँ, एक जूम में हूँ. जूम मीटिंग। तो राइट आर्म इधर है और लेफ्ट आर्म इधर है, सो दिस लीड विल बिकम लीड वन। So lead 1 is here. This will become lead 2 because this is now right arm, left leg. So होगा क्या ECG में, अगर मैं फिर से रिवर्स कर दूंगा, so AVL will become AVF and AVF will become AVL. So lateral will become inferior, inferior will become lateral. So सबसे पहली चीज क्या होगी, lead 3 will invert. And another very very important clue, P in lead 1, the P wave in lead 1 will become more than the P wave in lead 2. तो ये भी एक चीज है जो हम कई बार रियलाइज नहीं करते कि नॉर्मली ऐसा कभी नहीं होता। नॉर्मली द पी इन लीड 2 इज ऑलवेज टॉलर, स्लाइटली टॉलर देन द पी वेव इन लीड 1। आई शो यू एन एग्जांपल। तो ये उसका बेसलाइन ईसीजी था, एक्यूट इंफीरियर स्टेमी। नोट दैट द पी वेव इन लीड 2 इज टॉलर देन द पी वेव इन लीड 1। ये देख रहे हैं, पी वेव जो है किसी भी नॉर्मल पेशेंट का भी ईसीजी आप देखेंगे तो पी इन लीड 2 इज नॉर्मल देन द पी इन लीड 1। 2 hours लेटर का जो ईसीजी था, तो इफ यू सी दिस द लेटर ईसीजी, इसके अंदर क्या हो रहा है, नाउ लुक एट द पी वेव इन लीड 1। पी वेव इन लीड 1 is now more prominent than the P wave in lead 2. So पहला चेंज तो ये हो गया, और दूसरा है लीड 3 has become totally inverted. So अगर लीड 3 completely inverted है, P Q R S T दोनों पूरे inverted है, तो you should suspect a left arm left leg reversal. तो जब इसके नॉर्मल स्विच किए गए, सो इज बैक टू inferior column. So this is again a very very थेरेपेटिकली इंपॉर्टेंट लीड रिवर्सल, कि आप इंफीरियर को लैटरल भी बना सकते हैं जस्ट बिकॉज अ टेक्नीशियन और अ नर्स प्लेसेस द ईसीजी लीड्स रॉन्गली। तो आई विल कंक्लूड हियर सर दैट कई बार these ECGs are necessary. We have to analyze them with a good clinical correlation. And early diagnosis के चक्कर में, to close an early diagnosis, we are in danger of making a false diagnosis. So हमेशा in the proper clinical context, we have seen cases which I also showed that a large volume of fluid or air can change the flow of current through thoracic contents. So pneumothorax, pleural effusions also can lead to changes. And rushing such patients to cath lab or blindly giving them lytic therapy or heparin can be disastrous. So again, examining the patient once, taking a proper history. If you have time, looking at the X-ray, and have a checklist to rule out other non-cardiac conditions. So again, have a checklist ready कि auscultate हो गया कि नहीं, history ले ली कि नहीं, time हुआ तो X-ray ले लिया कि नहीं। And जैसे वो हम लोगों ने ICD के लिए भी patients कई बार जब भी refer होते हैं, again, it is very very important to rule out reversible causes. Didn't have time, but I'm sure sir के पास भी cases होंगे, and we have seen such cases in many meetings that patients who are coming with bradycardia at an early age, young onset bradycardia, especially mixed with tachycardia. So one should always rule out sarcoid in such cases because we are in a hurry to put in a pacemaker. But जब pacemaker लग जाता है, उसके कुछ दिनों के बाद one gets to know that the patient has got a drop in the LV function. So sarcoid is again a diagnosis which we are often missing. So these are important things to understand. So I'll conclude here, sir. I'll conclude. Thank you.
Yeah. Thank you, Aditya. As usual, wonderful uh, exposition. You have been a master teacher, I would say. There's a question at the chat box. Can NORAD be given in a patient with atrial fibrillation with low systolic blood pressure with a rate of more than 150 after giving shock, sir, if BP doesn't improve?
So
That's, yeah.
difficult situation है, अगर आप atrial fibrillation with hypotension है, the first thing has to be you have to cardiovert. So hypotension है, cardiovert करना है। अगर उसके बाद rhythm restore हो गया, the blood pressure should pick up. But if the blood pressure is not picking up, you have to rule out reversible causes. And because the downside of AD will be it can precipitate another arrhythmia, but if you need to give it, you need to give it. But more often than not, if it is reverted, the blood pressure should pick up.
That's wonderful. Thank you. Second question, the same doctor is asking, NORAD and dopamine induced narrow QRS tachycardia. Any additional treatment other than stopping vasopressors?
अगेन ये भी एक कैच 22 सिचुएशन है कि हाइपोटेंशन है, आपने नॉरएड और वो दिया डोपामिन, सो यूजुअली इट विल प्रेसिपिटेट अ साइनस टैकिकार्डिया and rarely होगा it will precipitate a supraventricular tachycardia. But if it has, then you have to strike a balance between dropping the rate of NORAD and inotropes and risking further hypotension. So maybe if you have a tachycardia, usually इतना tachycardia होता नहीं है, it is usually in the range of 120, 125, 130. So that is how you will have to do it.
The same doctor is asking role of magnesium sulfate in refractory VT.
Again, great
dose. Yeah, what is the dose and what is the appropriate route of administration, sir?
मैं आपसे भी सर इसमें इनपुट लूंगा, बिकॉज मैक्सेल्फ भी अच्छी एक दवाई है देने का फॉर वीटी. यूजुअली वी गिव इट इंट्रावीनस एंड वी यूजुअली बोलस 500 देते हैं, उसके बाद वी गिव अ 2 ग्राम इन्फ्यूजन ओवर सम टाइम. सो आपके आपके एक्सपीरियंस में सर मैक्सेल्फ का क्या रोल है?
Yeah, refractory VT is one condition where we have been using. Secondly, recently I had attended Dr. Narasimhan's atrial fibrillation symposia at Hyderabad. And this was a new learning for me that the success of cardioversion in atrial fibrillation can be improved by giving magnesium, IV magnesium.
Yes, yes.
And that was a new thing for me.
Absolutely.
And that I want to share this information to everybody, all of you who are listening to us. There's another question. Can calcium gluconate be given in hyperkalemia-induced arrhythmia with slow ventricular rate, less than 50?
एक आपकी आवाज सर ब्रेक कर रही है. कैन हाइपरकैलेमिया?
Can calcium gluconate be given in hyperkalemia-induced arrhythmia with slow ventricular rate?
तो कैल्शियम जो है हाइपर मतलब यूजुअली हाइपरकैलेमिया का ट्रीटमेंट तो अलग है, बट अगर कैल्शियम आइदर ग्लूकोनेट और क्लोराइड, इट डज रिड्यूस द रिस्क ऑफ वेंट्रिकुलर फिब्रिलेशन कॉज्ड बाय हाइपरकैलेमिया. बट द फर्स्ट इंस्टिंक्ट वुड बी टू गिव अदर एंटी हाइपरकैलेमिक मेजर्स जैसे कि इंसुलिन वगैरह देना, बट इट कैन रिड्यूस द रिस्क ऑफ वेंट्रिकुलर फिब्रिलेशन.
If echo is not available, what should be done of anticoagulant before cardioverting unstable AF?
आई थिंक अच्छा क्वेश्चन है, बिकॉज कई बार इको अवेलेबल नहीं है और अनस्टेबल एएफ है, आपको ड्यूरेशन नहीं पता, एंड यू आर कमिटेड टू गिव कार्डियोवर्जन. तो फर्स्ट थिंग इज, फर्स्ट ऑफ ऑल यू हैव टू एक्सप्लेन टू द पेशेंट द रिस्क ऑफ stroke. And secondly, if you are cardioverting, so there have been trials in his previous trials, older trials, कि you give a empirical dose of heparin of 5,000 and then proceed to cardiovert, but the risk will be there. So longer duration atrial fibrillation है. Again, similarly, अगर ऐसे ही longer duration में amiodarone देने से भी पहले थोड़ा सोच लेना चाहिए कि भाई patient anticoagulated है कि नहीं, because pharmacological conversion can also induce stroke. So you have to prognosticate the patient, and 5,000 heparin maybe, but cardiovert only if there is an emergency.
Can amiodarone be given if patient's blood pressure is less than 90/60?
तो इसमें भी सर से भी पूछूंगा मैं, बिकॉज ये भी डॉक्टर यश के फेवरेट एक चीज है कि आईवी एमेड्रोन ऑलवेज विल ड्रॉप द ब्लड प्रेशर. तो
Yeah.
one should ideally avoid it.
Is it that in last हाल में एम्स पटना में there are very important persons, doctor's father, he died. He, immediately after giving IV amiodarone, he had cardiac arrest. So is it, does it happen? Is it so?
नहीं मतलब उनका क्या मतलब कोई बैकग्राउंड में कुछ
Background, he had respiratory problem. He had severe bronchial asthma for a pretty long time. This time it was pretty severe. He was intubated. He was on vent. and he used to have, tachyarrhythmia. Somebody empirically used amiodarone, and then he had arrest, from which he could not be revived.
So I think, and he was hypotensive at that time. Yeah, blood pressure was fine.
The blood pressure was fine. Blood pressure was fine.
Did the monitor show any arrhythmia? Because usually hypotension and brady should be there, but अगर कोई prolonged QT baseline था because sepsis था, maybe he had a prolonged QT precipitated a torsades or something.
Yeah. So, if there are no question, then we all should thank the master teacher, Dr. Aditya Kapoor.
नहीं सर, आपके साथ हमेशा मजा आता है. आई एम प्रिविलेज ऑनर्ड.
Yes. We are all honored. Thank you. Good night.
सर, थैंक यू सर. बाय बाय. बाय बाय.